Important session of atrial septal defect and the clinical variants. We know it's an important exam topic, and many of the questions are related to ASD and how to diagnose a large shunt, and when do you diagnose Eisenmenger in a patient with ASD, and many things about ASD like a thrill, and when to diagnose a pulmonary stenosis, or in a PS when do you suspect ASD. So to take to this topic, I would like to invite Dr. Ranjan Shetty, sir. Sir is a great academician, a great teacher. I won't take much time. I'll directly hand over the session to Ranjan, sir. Sir.
Yeah. Thank you, Sudhakar. I hope all of you can hear. This is, this is a very important topic, as Sudhakar is told, and it's one topic which I really like to discuss whenever I, discuss, because it comes in lots of physiologies. And if you have understood this, you have understood congenital heart disease, because there's more to ASD than we see. The way it presents, the physiology with which there are at least 4 or 5 physiologies it presents, and they are so similar in so many ways. I'll be happy if you want to put in chat box, or if you want to unmute and ask questions, I'll be happy. It won't be a long session. It's not a guide on ASD. It's more clinical skill. Clinically, when you have a ASD, if you have a ASD in exam, it's like a definite case. In DM or DNB cardiology, typically we have 3 or 4 cases. One of them is very, very likely ASD. So one will be multivalvular rheumatic. The second one is very likely ASD. So if it is ASD, how do we pick it up, and what are the likely questions which are asked? ASD embryology, all of us have a great. This is something which we all know, but that is not what we discuss. What we are discussing. There is septum primum, then there is ostium primum. The septum ostium secundum is actually a break in septum primum, and then there is a flap-like connection. Now let's go to what we want to do. These are the 4 types, but clinically we do not distinguish them based on these types. That is very important. It's very difficult to clinically tell whether it is sinus venosus, secundum or primum, but it's more important for us to see which is the most important part. So let's see what is common. So let me come straight away to clinical, and there are 2-3 ways of looking at clinical medicine. So if I have to tell a simple example, from cough you have to read TB, from TB you have to reach cough. These are 2 diversely different way we approach case. So today let's not come from ASD to clinical. Let's go from clinical. What are the findings which tell us that this is ASD? So we are going back. So all our approach is based on clinical finding. Now ASD can come in multiple physiology. One of them is, say, shunting ASD. That means you have a ASD, shunt more than 2:1. Second, you have a ASD, shunt could be less than 2:1, little lesser shunt. What would be the feature in that? Now you could have ASD with torrential shunt. That will include Lutembacher physiology or a PAPVC. You can have ASD and pulmonary stenosis. You can have ASD and PAH, and you can have ASD and Eisenmenger. You can have ASD and cyanosis. So you're getting the very complex scenario here, and they're not mutually, they're practically mutually exclusive. Whatever we discussed is practically mutually exclusive. So it's very important for us to say which is the physiology. So just to repeat, ASD shunt more than 2:1, ASD small shunt, ASD torrential shunt, that is Lutembacher or PAPVC, ASD PS, ASD PAH, ASD Eisenmenger, ASD cyanosis. So you could have all this physiology, and one mistake what you utter in your exam, which may be a genuine mistake or something which you are uttering because you are stressed, could make all the difference in this case. So keeping this in mind, let's try to simplify this. Now, what is common to most of ASD? I won't say all ASD, most of ASD. If you find this, you will think there is ASD. And then based on other cut factors, you will think what is the added physiology. Now, what is common to almost all ASD is RV apex. Almost all of them will have RV apex with exception. The exception will come to later. So almost all ASD apex is RV. What does that mean? It's a diffuse apex, no retraction medial to apex, whole apex retracts medially, and apex is practically continuous with parasternal hip. So I'm going to repeat it. RV apex typically are diffuse. We don't too much concentrate on the force when it is diffuse. That means it will be in 2 intercostal space, or it is more than 2.5. It's almost always continuous with the parasternal heave. Since it is continuous with the parasternal heave, medial to apex, you cannot have any depression, and the whole apex retracts medially. So there is no retraction medial to apex. The whole apex retracts medially. So this is what we find. What you also find in almost all ASD is a wide fixed split. That means you hear split both in inspiration and exhalation, and it doesn't vary with respiration. That's what you find. Now, this is practically common to all ASD. Even ASD Eisenmenger has it. So ASD PH also will have it. So ASD by definition removes phasic nature of S2. So S2 is always phasic. Phasic means movement with respiration. It doesn't mean anything else. So the phasic nature is taken by ASD. You know, in your MD training or even before that, people tell you 3 liter blood coming from right side, 3 liter coming from left side. So it remains same. May or may not be true. In cardiology, we discuss about hangout interval. That means it is the property of distal vasculature, vasculature beyond P2, no, distal vasculature. ASD makes it fixed. That is the key cause why S2 is fixed. What you also find is an ejection systolic murmur. We can call it mid-systolic. So there is almost always, in most ASDs, you have a murmur. It doesn't start with S1. It is, you know, crescendo, decrescendo. It's not too long most of the time. It's a mid-peaking or little early peaking murmur. That's what you find. At this point, I actually want to stop and ask anybody, do you have doubt in any of these 3 findings? If you have doubt, then we stop here and discuss. If not, we go forward and understand how each physiology changes. Sudhakar, can you moderate? Can you ask someone, if you know any of your students who are there with us, could you ask them whether...
Yes.
Anybody who have understood this part, or is it, do you want me to repeat any of them?
I think at present we do not have, sir. I will interrupt if any. Yeah, can you explain the apex again, sir?
Yes. So apex here is, there's one question in the chat box. So if there is somebody, yeah, what causes ESM and apex, right? What happens to after closure? This is very good. So there are 3 questions now. So what causes ejection systolic murmur? Almost most of the time it is the flow, but it could be dilated PA itself. You know, even when the flow is less, the dilated PA also produces the ejection systolic murmur. So most of the time when we are talking about these physiology, it is ejection systolic murmur. Apex is RV. What do you mean by RV apex? So again, I think Dr. Gaurav has asked the same question. Very important. In clinical examination, only 2 or 3 things are important. Obviously, JVP is important. Auscultation S2 is important. Palpation, it is apex and parasternum. So how do you distinguish RV and LV? LV apex is most of the time localized, and it goes to the left side. It deviates to the, there will be retraction medial to apex, and apex retracts laterally. Whereas RV apex is diffuse retraction. The whole apex retracts medially. Lateral to apex, you have retraction. Okay. So this is what is LV and RV apex. Now there are 2-3 questions. What happens to S2 after closure? It remains, that time it is not fixed, but it is wide but variable. Does the murmur persist after closure? It can persist, not because of the blow, because the PA is dilated. A short ejection murmur is what can persist even after closure. What is very important after closure, the fixed, it's still wide, but it's not fixed. It is wide variable. Reason being the distal circulation beyond ASD, that is the pulmonary vasculature, doesn't become completely normal. There is some change which occurs in vasculature. So whether you close or no, the vasculature doesn't become normal, but the fixed nature goes if there is this. There's a very good, interesting question about small shunt. I'll be coming to that very soon. Wide fixed murmur, it's not the murmur, it is the split which is wide fixed. Murmur is ejection. So almost all physiology, with exception, we are going to come to that exceptions, have these three features which is common. Now let's go one by one. I'm happy all of you are following it. Let's go one by one. Small ASD. Nothing. That is important. If the ASD is extremely small, like so small that there is no RA-RV dilatation, there is nothing, then nothing happens if it is very small. But if it is slightly smaller, maybe, somebody wants to know about hangout, I'll come to that. If it is slightly, if it is like say 1.5, in such a case, a ejection murmur can be there, but there may not be S3 or there may not be MDM. So typically, let's see clinically. Clinically, if it is a very small ASD, which is hemodynamically not significant, you will have, it will look normal. So you don't worry about that. That is something which we don't have to discuss. Practically discard it. It will be normal. Okay. Now let's come to the next one. Not the next one. Large ASD. That means you are saying clinically shunt is more than 2:1. Now, what will a large simple ASD look like? That means it is an ASD which could be any of them, primum, secondum, whatever you know. But this is an ASD which has produced the shunt more than 2:1. So how will this appear? This will have three characteristic features: RV apex, palpable P2, and ejection. No, more important, wide fixed. The three common features will be RV apex, ejection systolic murmur, and the wide fixed S2. These three will be common. Now, what will be extra? Extra will be features of flow. Now, features of flow are RVS3, RVMDM, and a parasternal heave, which is forceful, ill sustained. That means if you have to know, the 2-3 things. When we are discussing ASD, we should assume that you already know what apex is and how does the parasternal behave in different condition. I'm sure we have had some lectures last time. I think we can, Sudhakar can maybe send it of the discussion which we have. I think if there is a recording, we'll share it with you. But here, parasternum, which is forceful, ill sustained, synchronous with the apex. That means when you say synchronous, it is RV, it's forceful, ill sustained. So in a shunting ASD, apart from features of RV apex, ejection murmur, and wide fixed split, you'll have features of flow, more flow, not more pressure, but more flow. That is RVS3, MDM, and a heave. Now, it's very important. That means your whole diagnosis here depends on the fact that you can actually auscultate S3 and MDM. Now, is it difficult or is it easy? Something which we should train ourselves to pick up. That's something which is very important. That means you need to keep your, these are low pitch sounds, so ideally you should keep your bell, but you can keep your diaphragm, but very, very slow, and you push it hard. As you push it hard, something disappears. So do not expect these MDMs to be like MS MDM. It's not rough rumbling. The flow MDMs are not like MS MDM. So it's not rough rumbling. The flow MDMs are actually absence of silence of diastole. That means in diastole, you don't expect anything, but here you're hearing something. So it's practically like S3, which is slightly pulled. So make sure you keep your bell or diaphragm very lightly. You hear something, just concentrate on diastole. Later you push it hard. As you push it hard, you realize that something is disappearing and you don't only hear systolic events. That is the MDM or S3 which you are hearing. More and more you train yourself, you will be able to do. I think somebody's already put palpation back for you in the chat box, so you could go through that. So please remember the difference. This is the hallmark. The hallmark is hearing S3 and hearing MDM. It's not that difficult. That's the point we should understand. It's not that difficult. It is simple. But do not, all MDMs are not MS MDM. These are different. So just look for that. You'll also get a S2, which is loud now, and it's wide, so it is palpable. And most of the time, very interesting feature here, you also get a systolic PA pulsation. There are two things which happens in PA. One is a diastolic palpation. The S2 is diastolic. It's called diastolic shock. Whereas because of the increased blood, if you keep your this one, just like you feel carotid pulse, if you keep it in the systolic second intercostal space, you also see a systolic pulsation which occurs here. So that's what you get here, systolic pulsation of the this. So there's also Vaibhav has asked the question, how do you distinguish RVS3 and MDM? They are different, but they're very, very close to each other. S3 is a sound. So S3 will appear like a split S2, but low pitch. So you keep it down. This is something which I always tell. Do not try to have 240 events. Even if heart rate is 60, if you are auscultating in a minute, you'll have S1, you'll have S2. That is 120 events. Imagine if you define anything else beyond S1, S2, you're going to have 240 units in a minute. Just not possible. However intelligent, smart you are, it's just not possible to distinguish. So always correlate with sounds. So S4 and clicks are like split S1. So they're very close to S1. They're like split S1. S4 is low pitch. That means it will be heard when you keep it light. If you press it hard, it disappears. That is S4. Whereas click, most of the time, vascular click or valvular click are again like a split S1, but they are high pitch. Similarly, you have opening snap and you have S3. They are like split S2. So like split S2, they are like, split S2. So again, you keep your stat here. And if you find a split S2, which is low pitch, it's likely S3. And if you like a split, F3, but high pitch, it's likely to be opening snap. With exception, this is how we make. There's also an interesting question during COVID time cardiology examination. Fortunately, your exam has become much easier now with all the, OSCE pattern. But yes, if you are forced to examine, you have to make sure patient wears mask, you wear mask, and then, you need to go ahead with that. So I hope all of you understood a simple garden variant, large S2. That means you'll have all three features with features of flow. Now, if you're fine with this, I'm going to go to the next, because these two are important. What is common to all ASD, but believe me, we have just discussed one type of ASD. So the next one, if you want to go, any doubts here? Yes, I'm also going to get an exception here. I started by telling almost all ASD will have RV apex. The exceptions are if the problem is in LV or if the problem is in aortic wall, you could actually have LV apex. Otherwise, almost all ASD will have RV apex. So if ASD is having a LV apex, problem is in LV or aortic wall. If ASD is having mitral valve problem or any other ASD, will actually have RV apex. Okay. Now the next physiology. This is where you have ASD, but you also have a thrill. That means, everything is fine. You feel there is a torrential shunt. You have RV apex. You have some parasternal heave. You have some thrill, but you also have a thrill. Now, what does it mean? That means there is ASD now with torrential shunt most of the time. So there are 4 possibilities which are there. So let's list them, and if possible, try to distinguish each of them. One of them is large ASD itself. Up to 25% ASD can have thrill. So when you have diagnosis of the ASD with thrill, make a diagnosis of ASD with thrill. Lutembacher, which is almost always acquired mitral valve disease, could be MS, could be MR, is one important cause. And then pulmonary stenosis with ASD also has thrill and features suggest, we'll come to that. And the other cause could be a PAPVC, that means partial anomalous pulmonary circulation. Now, ASD with thrill. Let's discuss Lutembacher, which is very important. You can never say Lutembacher in exam. That's the first point you should understand. Unless there is a history of rheumatic, carditis, arthritis, whatever, there is a specific history, patient on Benadryl. Otherwise, you don't make a diagnosis of Lutembacher. You only make a diagnosis of ASD with thrill or ASD with torrential shunt. What happens is apex will still be, as we discussed, any mitral valve lesion with ASD will still have RV apex, but here the shunt is torrential. See, before that, we need to understand what decides shunt in ASD. Is it size or is it something else? Typically in ASD, to understand ASD physiology, we need to understand the shunt in ASD is decided by RV compliance versus LV compliance. So whenever typically RV compliance is lower, so the shunt is more left to right. But if you have mitral inflow disease, like here, mitral inflow has a problem, obviously there will be torrential shunt on the right side and you will have thrill. So in these cases, RVS3 will be very easy to find. RVMDM is easy to find. You palpate, you get a thrill. You also get a PA pulsation, which is systolic. You also get a S2, which is palpable, which is diastolic. One very important feature of Lutembacher is JVP is raised in 90% of people. In Lutembacher, the JVP gets raised in almost all of them. 90% of them will have JVP raised. So Dr. Arun has a question, where will we find the thrill? It's in the second space. This thrill, it's a flow murmur, but because the flow is so high, you're getting a thrill here. So it's not anywhere else. Do not try to get opening snaps. It's nearly impossible to get in these physiology. Stick to ASD with thrill, probably Lutembacher. That's how you should put this. Don't jump up, even though somebody has told you the echo diagnosis. Don't jump up. So raised V wave or A wave, both are possible, because MS also can have V wave, which we keep discussing, but generally both can happen. Most of the time, because LV pressure is transmitted, the V wave rise will be more than A wave, but JVP rise is invariable. So because JVP rise, technically Lutembacher patients are in failure, because rise JVP is failure as far as we are concerned. In exam, when you put, almost all Lutembacher's are actually in failure. So thrill, huge parasternal heave, which is most of the time volume. That means it will be ill sustained. It could be grade 2 or grade 3. MS feature almost completely masked. S3 MDM are banging. You cannot miss a S3 MDM. More important, do not make this diagnosis. Okay. So that is, do not call it Lutembacher, call it ASD. Most of the time, ASD is congenital, MS is acquired. All of you people ask you this question: what is the chance of having MS with ASD? What is the chance of having ASD with MS? These are very typical questions. MR also is possible. It's not this. Generally, if you have a, say, a cleft AML, or if you have primum, which almost always has MR, if you have rheumatic MR, 3 MRs are possible in ASD. One is primum, where cleft AML, which is not a real cleft, but discontinuation in the superior bridging leaflet, or you could have MVP, which is 80% in ASD. So they also can lead to MR. And third possibility is rheumatic. All 3 MRs are possible here. So this is Dr. Bashi's series, which was published from CMC Vellore. It's a very interesting series, so I would recommend that people should read it before you understand Lutembacher. I will not go to this. So the other possibility is having a PAPVC, not just one vein, maybe two veins joining. This is not just PAPVC. We are not talking about ASD with PAPVC. If you have just PAPVC, then it will be wide variable fix, a split. But most of the time with PAPVC, with ASD, the shunt increases. You might ask why. Because ASD, both the chambers are communicating, but as long as the pulmonary vein drain to RA, compliance is always less than LA. It's not about pressure, it's about compliance. RA compliance is better than LA. So the shunt increases, and that also leads to ASD with thrill. The third interesting point, that means we discussed ASD with thrill, 4 causes. One is simple ASD. 25% of large ASD can have thrill. There is no features of Lutembacher, but you have features of torrential shunt with thrill. Then Lutembacher, invariably there is failure, banging, but again you don't have to tell Lutembacher, you have to tell ASD with thrill. Third is ASD with PAPVC. Again, with the ASD PAPVC shunt increases, you could have a thrill. And the fourth is ASD with PS. Now this is interesting, because this is a variable physiology. When ASD with PS itself is a big topic, so it's a variable physiology. So if you have a mild PS, there are 2-3 things here. One, is the PS actually there? So if you look at echo, if you look at Moss and Adam, just because of ASD, you can have gradient up to 40. Both cath and echo, you can have gradient up to 40 just because of ASD itself. And rarely you can have gradient up to 70 just because of ASD itself. So if there is a mild PS associated, which is not that uncommon, you could, because of the flow acceleration, you could have a thrill now. The shunt is there, but because of PS, there is a thrill. But here the PS is mild, so it's only producing flow acceleration. So other than the features of flow, what we could find here is 2 things can happen. One, you could get a valvular ejection click, which is because of the pulmonary artery, PS. But because of ASD, that phasic nature might disappear. You would not get, a right-sided event. Best heard in expiration may not happen because there is already ASD. So you will hear a click here, which is like a split S1, which we discussed in the base. Lower down, you could hear a click. And please follow this sentence again. So you could have a click. The second thing what could happen is the second of the second heart sound, which means P2 could become softer, because almost all ASD P2 is loud. It's as loud as A2, minimal. It's most of the time palpable. So because of the PS, it could become softer because there is an organic problem in pulmonary valve. The P2 could become softer. It will still be wide fixed split as long as ASD is deciding the hemodynamics. It will be wide fixed split, and the P2 could be actually soft. These are the features which can happen. But what would happen if there is a PS which is severe, so severe that it is behaving like a TOF? This is what we call as triology. That means if the ASD is, if the PS is severe, yes, the Priyank Singh is asking a question. Is the pulmonary click heard in lower sternal? Yes, all clicks are heard at the, they are heard towards the lower part. Aortic clicks are best in mitral area. Pulmonary clicks are better in tricuspid area. They're not better in this. If the PS is severe, that means now it's like triology. That means RV is thick now. RV compliance could be less than or LV compliance. The shunt could reverse. Now this patient has ASD, has PS, but because of PS now, he's cyanotic. The shunt, it's, the reversal takes place. So it is cyanotic. That means we need to ask two questions here. So it could mimic a TOF. So as long as the RV compliance because of PS becomes worse, the shunt reverses. So here the question which is asked in exam clearly is, how do you distinguish PS ASD from PS PFO? So this is something which is asked. Can somebody unmute and answer this question? PS ASD from PS PFO. So when you tell ASD with PS could be mild, in which case it will be ASD with thrill. PS could be severe, in which case the whole physiology changes. So anybody wants to answer this? Sudhakar, you choose somebody.
Yeah. Dr. Harnish is there.
Yeah.
We can unmute him. Rahul, you can unmute.
Yes, sir, I have allowed participants.
Harnish,
Yes.
you can answer. Yeah.
Good evening, sir.
Yeah, good evening, Harnit.
So
So how
can
do
you
you
please
distinguish PS PFO and PS ASD, assuming PS is the dominant physiology, okay?
assuming PS is the dominant physiology?
Yeah, we are not talking about those mild PS which is accelerating the ASD flow. We are talking about a PS which is very severe, but there is an atrial level communication which is allowing cyanosis. But the question is whether the atrial level communication is ASD or PFO.
Usually the PFO won't shunt from left to right, sir. So the split which is fixed in ASD will not happen in PFO because of that reason.
No, here there is cyanosis. You know, the problem is there is cyanosis, and we know it is not TOF. So the question is, how will you distinguish PS PFO from PS ASD? So the answer is the PFO shunts only after RV fails. Okay. So such a patient will have JVP rise, pedal edema, and then the PFO gets stretched and the shunt occurs. Whereas in PS ASD, PS and there is ASD, the shunt can occur even before RV failure, because the determinant of shunt in ASD is a relative compliance between RV and LV. So because of PS, RV becomes thick, even without failure, the shunt can be right to left. So they could have initial exertional cyanosis followed by later cyanosis without gross RV failure. Is the answer clear?
So there is crescendo D.
Yes.
There is a kite-shaped murmur which is occupying more than A2 also, no, sir?
Yeah, that's because of the severe PS. But if you have an isolated severe PS, it's not cyanotic, right? It's
yes, sir.
cyanotic. Yeah.
So, because ASD with PFO will be always cyanotic.
Yeah,
no, sir,
not
because of
always,
the-
not always. If PS is severe, it is so severe that it has made the RV compliance bad compared to LV, it becomes cyanosis. But remember, if it is PFO which is shunting, there is always it's after RV fails. If it is ASD which is shunting, it can shunt earlier. Okay, but if ASD PS is mild, if PS is mild, then it will behave like ASD. If PS is severe, it will behave like triology of TOF. Okay. Okay. Now let's see this. So I know most of you know this. We did discuss sometime it's difficult to pick up mild PS in presence of ASD. Up to 40 is okay with Moss and Adam. Now let's see other physiology here. Okay. So we saw lots of physiology. I hope you are not confused. If anybody is confused, please unmute and ask me to repeat anything. I think Suryakant is there in other sessions also. Any doubts, Suryakant?
No, sir. No, sir.
You followed this. Yes.
Yeah.
I saw Afzar. Afzar, did you follow?
Yes, sir.
Okay. So let's go with ASD with PAH. That means now there is ASD. So you will have RV apex, you will have wide fix S2, and you will also have a ejection murmur. Now there is PAH. Now two types of PAH are possible. One pH is because of the flow. That is called hyperkinetic pH. That means it is just because of the flow. The second pH is like Eisenmenger. It may not have Eisenmengerized, but it's going there. That's what we call as obliterative pH. That means in one, the PA vasculature is fine, but because of torrential flow, you are getting a pH. Now this is like, hyperkinetic is because of the flow. So in these, usually, you will have a parasternal heave, you'll have RVS3, you'll have MDM. So RVS3, MDM are hallmarks of flow. They will be present, and hyperkinetic parasternal impulse. That means you're forceful but ill-sustained. Rarely it can become sustained also, because sometimes RV cannot distinguish between pressure and flow, but most of the time, as long as flow is the one which is producing pH, that means S2 is loud, P2 is loud, P2 is palpable, and the flow is actually producing the heave. So you could have grade 2 or grade 3 parasternal heave. Most of the time it is flow related. That means it is forceful, ill-sustained left parasternal heave. Almost always RVS3 and flow murmur is present. But what we are worried is obliterative pH, and this is examiner's favorite. So here what you have is, you have a pH and you also have a ASD. Because you have ASD now, the RV apex is present. You'll have a wide fixed split, loud P2, palpable P2, ejection murmur. This much you have. What else you have? You don't have RVS3 MDM. This is the importance of RVS3 MDM. If you are not able to pick it up, your diagnosis changes. So as long as you think shunt is more than 2:1, you must get RVS3 MDM. But in natural history of ASD, it is possible that the PA is now changing. That means there is a like Eisenmenger-like changes occurred. It may or may not have fully Eisenmengerized, but the pulmonary vasculature changes have occurred, just like PPHN or primary pulmonary. So some changes occurred. The pressure is increased in the pulmonary circulation, and that has reduced the shunt. The difference here, you won't find RVS3 or MDM. You will have a parasternal heave, which will be grade 3/3. It's not the grade which is important. It is sustained. That means more than 50% of the systole it is covering, and it is synchronous with apex. Synchronous just means it is RV and not LA. So it's synchronous. That means there is RV force. This RV force is because of the pressure, because the parasternal heave is sustained. It's more than grade 2 or 3. It doesn't matter, but most of the time it is grade 3. You will not have a RVS3 and you will not have a murmur. So if you have this kind of finding, the person may be, most of the time these are acyanotic or minimally cyanotic. You may have to make this person exercise, put a pulse oximeter, and look for desaturation which is present, and such a person can have a click. Now the interesting point, and this is what Dr. Arun is asking in your chat box also, how do you distinguish a valvular click from a vascular click? So in this case, you'll have a vascular click, So clicks are classified. There are 3 classifications for click. One is vascular, non-vascular, ejection, non-ejection. That is the first calculation. Non-ejection are MVP kind of click. Ejection are something related to ejection of the ventricles. So along with this, it could be valve, which could be aortic or tricuspid, pulmonary valve, or it could be vascular. That means it's related to aorta or PA. Now both these, most pulmonary valvular click are phasic. Phasic means changes with the respiration, and it's best heard in expiration. So pulmonary valvular click is best heard in expiration. Whereas pulmonary vascular click, which is because of the dilated PA, is best heard in inspiration. How do you distinguish? Feel for the carotid pulse. All clicks will be like split S1, but high pitch. That's what we decided. Feel for carotid click. If it is vascular click, it is usually with the carotid because it needs some time. It's in the mid of the ejection. So it's with the carotid when the carotid rises. If it is valvular, most of the time it occurs just before carotid. This is one place where, most of the time I tell you, don't go before, don't go after. But this is one point. The way to distinguish is only this. Feel for carotid, and if it occurs with the peak of carotid, it's vascular. If it occurs just before, it is valvular. Valvular also has its own characteristic. So here, because the PA is dilated, you will get a click which is vascular. Okay, it's very common and it will be present. You'll also get a split S2, which is wide and fixed, and P2 is loud. You can also get a PA pulsation. It's not that common but just because of the force, you could get a PA pulsation. But PA pulsations are more whenever the flow is more. So if you find these features, your diagnosis should be ASD PH. If you find a hyperkinetic pH, your diagnosis is actually ASD shunt more than 2:1 with hyperdynamic pH. If you find only this, you will call it ASD pH. You will not comment Eisenmenger because you are not sure about that, but you will call it ASD pH, and most of these patients require cath. Yes. So next is, I hope we are followed. Sudhakar, I hope everybody is followed. What's your opinion?
Yes, sir. I think
Okay.
everybody is active in asking also the doubts.
Yes, hopefully they are followed. No, yeah. So now ASD with Eisenmenger. That means now there is clear cyanosis. Eisenmenger, there is no borderline because Eisenmenger word tells us it is irreversible. So there is a clear-cut cyanosis now. And the classical, one of the Eisenmenger discussion will tell ASD Eisenmenger almost always in failure. JVP will have TR is present. JVP will have a prominent B wave, but fix will be again wide split. S3 may be there, but no MDM here. And you will still have an ejection murmur in pulmonary area. This is but worry is the previous one. ASD PH is the worry, and your ability to pick up RVS3 and MDM is something which you need to train yourself. That is when we call ASD with Eisenmenger. So, yeah, I don't want to go to these things because they are, very specific case, and I don't want to go too much here. But I just want to discuss cyanosis in ASD. Not all cyanosis in ASD are Eisenmenger. Eisenmenger obviously is one cause which is there. So cyanosis in ASD is invariably asked. Persistent, prominent eustachian valve. That means IVC valve is very prominent. It can shunt part of the blood to LA and produce cyanosis. LSVC to CS doesn't produce, but LSVC directly to LA, we have reported a case recently, or unroofing of CS can produce. TAPVC, single atrium. Sinus venosus, very interesting. Sinus venosus has triad. It has three components, sinus venosus. The one component is obviously ASD. Second component is the right upper pulmonary vein, now in RA. The third component, which people don't discuss, is a SVC, which is overhanging. In sinus venosus, SVC is committed both to RA and LA. That can produce cyanosis. ASD with PS, where the PS is severe, it will be, you can have cyanosis. RV dysfunction, again, because in ASD shunt depends on RV versus LV compliance. Any RV dysfunction, moderate RV dysfunction can produce cyanosis. Platypnea orthodeoxemia is a special condition which occurs in PFO with it's the opposite of orthopnea. Sitting up patient, cyanosis, lying down better, opposite of which occurs. Wide fixed S2 other than ASD is TAPVC, where there could be cyanosis. Any RV dysfunction with RBBB. RV dysfunction with RBBB also produces a wide fixed S2. Massive pulmonary embolism also produces. See, when you say wide split S2, you're actually saying there is no respiratory variation. When does that happen? if the hangout interval, that is, if the pulmonary vasculature is maximally dilated, it happens. It also happens if there is RB dysfunction and RBBB, or something like a major pulmonary embolism, which is now not changing the flow to pulmonary artery. This one will be wide split. So somebody did ask this question, in our chat box to explain this. I don't know who was the person who, yeah, somebody did ask about, I think, hangout interval. Yes, that's important. In ASD, the key important is hangout interval. What is hangout interval? Contrary to popular belief, which we always think it is the pressure which drives the blood flow. It's not true at all, because whenever there is a shunt physiology, whether it is ASD, whether it's a large VSD or large PDA, the pressure between two chambers are same. That's what we learn in cath classes. So most cath classes, what we learn is the pressure between the two chambers are same, as long as the connection is wide enough. It's like two rooms, you connect, the pressure is same. Then what decides the flow? If the pressure is same, the flow is actually decided by the distal vasculature, distal system. That means it is most diseases, it is the pulmonary vascular resistance versus systemic vascular resistance which decides the flow. In ASD, it is RV and LV compliance, because the next chamber is RV and LV. But in VSD and PDA, it is pulmonary vascular resistance versus systemic vascular resistance. Now imagine the RV is now ejecting, LV is also ejecting. But at point, all of us know the graph. At one middle of that graph, the pressure between RV and PA, RV overshoots PA and P, they're almost the same. And LV overshoots iota. But then the closure of the semilunar wall doesn't occur at that point. It occurs way later. So the time interval between the transfer of the pressure between RV and PA versus pulmonary valve closure, and similarly for the left side, indicates that that is the hangout interval. That means it's the time between the pressure closure, pressure transfer versus the closure of semilunar valve, and that is decided by the distal circulation. So it's basically decided by pulmonary vasculature. Inspiration increases decreases the resistance, because you take a deep breath and the flow is going, and exhalation decreases it. So normally almost everybody has some variation of this impedance, and hence the hangout interval changes. But ASD, since it's a congenital heart disease occurring very, very early, actually produces maximal changes in pulmonary vasculature. So the hangout interval becomes fixed, the pulmonary vascular impedance becomes fixed, and hence there is no A2 P2 gap variation which occurs with inspiration. That is the real reason why ASD has fixed split. It doesn't change even in Eisenmenger, because it is same. When you close it, but the flow part changes. So hangout interval is something which you should understand. All congenital entry, it is important. What happens to hangout interval case of VSD? It changes, but not to the extent of ASD. Hence, the wide fixed split is because of A2, early A2 and not delayed P2. So early A2. What's very interesting, Arun, is what happens to hangout interval in PDA? Can anybody answer how does hangout interval of PDA affect S2? Madhusudan? I'm just randomly calling the names which are there, so don't feel bad. Feel free to answer. Tushar?
There would be reverse splitting in PDA, sir.
Exactly. Who answered this?
Sir, Kiran, sir. Kiran.
Yes, Kiran. Why does that happen? You get a paradoxical split in PDA, no?
Yes, sir. Yes, sir.
Why does it happen? Can you explain it to all of us, Kiran?
Sir, because there is increased flow in the pulmonary flow, sir, during the systole as well as the diastole, sir. So the pulmonary artery takes the pulmonary wall takes longer time to close as compared to the aortic, sir. So that's why there is reverse splitting in PDA, sir.
No, that doesn't explain, Kiran. If pulmonary is taking longer time, you should have wide split. No?
Sir, it's because of there is a LV volume overload, sir, and that leads to the delayed A2, sir. And it's the reason for wide
Yes.
paradoxical split.
Yeah, so delayed A2 is the reason, no doubt. But you know the real reason in when we are discussing all this, is mainly because the hangout interval now affecting the left side, because now aorta is connected to PA. Because aorta is connected to PA, that hangout interval get transferred to the systemic circulation, and hence A2 gets delayed. So paradoxical split is very interesting, and it occurs only in shunting PDA. And later, when there is a PDA Eisenmenger, it becomes narrow split. So remember, hangout interval does play in lot of congenital heart disease. Okay. So variable split and all these are, I think we should not be discussing all this. So we will stop at this, and I think this is the hangout interval which we are explaining. I can share these slides if you want. It's also interesting to discuss ASD ECG, but I think we should do it sometime else, because too much discussion on one day doesn't help anybody. No? What do you say, Sudhakar?
Sir, one question, sir.
Yeah.
Sir, how
Kiran, no? Yeah, Kiran.
Yes, sir. Sir, how to differentiate between ASD PFO and ASD PS, sir?
You are asking PS PFO and PS ASD?
Yes, sir. Yes, sir. Yes,
okay.
Sir.
So yeah, that is what we discussed. So imagine there is a PS which is very severe. Okay. So we are talking about a PS which is very severe. It's a significant PS. You have a pressure overloaded RV. You have a long murmur, and you have a split which is wide, variable with soft tissue. PS is not in doubt. Now, such a patient is cyanotic. Only then we are worried. If you are acyanotic, there is no question. So now, cyanosis in a PS intact septum means that there is an atrial level communication. Now, atrial level communication could be two. It could be a PFO or it could be ASD. Now, from today's class and what we have been discussing is that whenever we discuss about ASD, the shunting is because of relative compliance between RV and LV. So because of PS, RVs become stiff. So reversal of shunt takes place. This takes place even without failure. RV is not failed, JVP is not raised, but person now has cyanosis. He has features of PS with intact septum, good force, dilated PA, but there is cyanosis. So that means the shunting is from ASD, because ASD does not require failure. But imagine there is no ASD, there is only PFO. Now PFO has to stretch. Only when it stretches, the shunt can be right to left. When will atria stretch? Only when RV fails. So if RV fails, there is too much TR and atria stretch. So PFO, PS PFO will shunt only with proper RV failure. Sky high JVP, pedal edema. That's when a PFO will shunt, whereas ASD can shunt just because the compliance of RV is now worse than compliance of LV. Okay? Followed, Kiran?
Yes, sir. Yes, sir. Yes, sir.
Okay. So I think Drishti has a question about hangout interval. So hangout interval is from the crossover of the pressure to actual closure of semilunar valve. So crossover to semilunar. On right side, it is longer because the pulmonary vascular resistance is lower, and left side, it is narrower. So once, what we are trying to tell is pressure between the ventricle and the great artery is same, but still blood decides to flow to great artery to some extent according to the resistance of the chamber beyond.
Sir, I have a doubt, sir.
Yes.
Sir, usually after pulmonary hypertension, the split narrows, sir. In every other condition, sir, in ASD Eisenmengerization alone, even after Eisenmengerization, the split is wide and fixed.
Yes.
Here also the peripheral vessels are, that a split is decided by the peripheral thing, hang out in peripheral. So why
This
so,
is Rahul, is it?
Sir, Suryakant.
Suryakant, yes. Rahul also asked the similar question. So the answer to this, it's a very interesting question. So imagine you follow a child from birth till they are Eisenmengerized. Okay. If you do that, so there are two aspects. What is a wide fixed split? What is a wide split? Wide split by definition is one which is heard both in inspiration and expiration. Okay, that is wide split. That means you hear a split both in inspiration and exhalation. If you hear, it becomes wide. What is wide variable? It changes with respiration. Now, as we discussed in ASD, there is a change in pulmonary vasculature, which probably is from birth. Okay, the change is from birth. Even before the child is born or just after the child is born, some vasculature change occurs and that persists. Now, once the Eisenmengerization sets in, the split definitely narrows, but it is narrower than what it could have been with shunting ASD, but it will still be wide. Because of the change in inherent change in pulmonary vasculature, it will be wide. And because of ASD, there is no respiratory variation. That means split will be heard both in inspiration and expiration. A2 P2 gap will remain. It will not alter with breathing. But if at all, if you had followed the child from birth to Eisenmengerization, which might become a criminal offense because you should have intervened somewhere in between, but if you have followed, it becomes narrower than what it was. So it still remains wide but fixed just because of the definition. Most PAH, again, ideally you should use the term normal split. What is a normal split? Split in inspiration, single in expiration is normal split. In PH, we believe it is narrower than normal, but using normal split is okay. What happens to hangout interval in reversal of the shunt? It does reduce, there is no doubt about that, but the reduction is not complete, it's not absolute. Still, the right-sided, that is the pulmonary vascular, compliance will still be slightly lower than systemic, which is always there. It doesn't change. So ASD is one exception where the split still remains wide and fixed. Any other question?
Sir, I have a few questions related to that.
Yes, Sudhakar. Yeah.
ASD with TAPVC can cause still a thrill in the, not PAPVC, TAPVC.
Once you use TAPVC, actually, Sudhakar, then the ASD is part and parcel of the disease. If there is a torrential shunt, yes, it can produce thrill. But the problem there is, it's more like ASD, it's a different disease to start with, which has obligatory ASD.
Right.
It's obligatory, there's no option, but disease is different. It's wrong to classify it with ASD actually.
And many people will a sinus venosus ASD also produce a wide and fixed split?
Yes. It doesn't matter. That's what we started. Actually, it just doesn't matter whether it is primum, secondum, coronary sinus, SVC type of sinus venosus, IVC type of, just doesn't matter, because decision of the split, shunt is only decided by RVLV compliance. Split is decided by pulmonary vasculature. What it can have is sinus venosus. The difference is you could have low atrial rhythm. ECG we didn't discuss, no? You could have lower. Almost all of them will have RSR dash. PR is prolonged in familial ASD. In sinus, primum, you could have left axis deviation, and in secondum and in sinus venosus, you could have low atrial rhythm.
And many students ask, what happens to the findings of MS in Lutembacher? Like what happens to the...
That's very interesting. Okay, very, very interesting. What happens actually is, because the shunt is now, because if the MS is significant, the shunt actually becomes left-right torrential. So hardly any blood is actually flowing through the mitral valve, and the mitral valve is hidden because RV is so big now. The mitral valve is actually hidden behind. The apex itself is RV. So you hardly get signs of MS. Only sign you can get is an opening snap which can occur even in, opening sounds can occur even in ASD. So do not make that sound this at all. So just call it ASD with torrential shunt. If ASD is very small, then you will have features only of MS. So usually in Lutembacher, don't jump into Lutembacher. Just call it as ASD with torrential shunt. Most people try to, because they know the diagnosis, they try to get some finding of MS. You lose mark if you get finding of MS. Don't get signs of MS.
Yes, sir. One of the questions here: what happens to the split S2 in pulmonary hypertension?
Yeah, normal pulmonary hypertension in absence of ASD actually has what we should ideally call as normal split, because you have split in inspiration, you have single in exhalation. So you should ideally call it normal split with loud P2. That's what you should call it. But if you want to call it narrow split, that means you are telling in inspiration, split is narrower than normal. So compared to normal, it is narrower than normal. And in exhalation, it is single. It's okay to call it. That is normal because now the PVR becomes higher and the right-sided hangout interval decreases. But ASD Eisenmenger, ASD PH is a different ball game altogether.
Right, sir. I think we have finished all the
questions, no?
Sir, one question, sir. Narrow split should be mentioned in the exam, sir?
No, ideally, no. You should actually use, what will be preferred is normal split with loud P2.
Okay, yes, sir. Because
that's the preferred.
Yes, sir. Yes, sir.
But again, this in clinical examination, there is a north, south, east, west divide. So we don't know where your examiner is coming from. Since I've been trained in both this way and that way, I know most of these questions which are asked. Be very flexible. That helps.
Okay, sir.
right, sir.
Yeah.
Anybody has any other question, they can just unmute themselves and just
yeah.
Otherwise we will. I think we have covered almost all the variants of ASD, sir.
Yes.
ASD, large shunt, Eisenmenger, thrill with, and all other variants.
Actually, yes. And one more thing, what we don't discuss, please don't get confused. What we don't discuss this too much. What happens is, imagine you have a 60-year-old or 65-year-old ASD. Okay, such a patient also can have thrill. The reason being, they don't have Lutembacher, but they have diastolic heart failure. That also produces torrential shunt. So we have had some patient. So if at all, imagine a situation where RV is failing, there is pedal edema, there is RV failure, IVC is dilated, and again you see a torrential left to right shunt. Ideally, whenever RV has a problem, shunt should actually reverse. No, if it doesn't reverse, if it's still, then remember there is a problem with LV in such a patient. Maybe systolic, maybe diastolic.
Right. So we'll conclude here, sir.
Yes.
So thank you very much, Ranjan sir, for this exhaustive session. I think this is one of the topic which I have not seen much being discussed in last 1 year in any clinical session. So I thought this topic will be helpful. And this is one of the short cases when everywhere we get, let it be in MD or in DM, DNB. So, and looking forward to more such classes from you, sir.
Thank you, Sudhakar. Okay. Take
Rahul.
care. Bye. Stay safe. Yeah.
So we are now towards concluding this program, and I must say this has been one of the most interactive sessions. So we with Dr. Sudhakar Rao, we've been doing this PG webinar Bonanza series, but this has been one of the most interactive sessions. So thank you for your time, and we look forward to partner with you in this consistent program, sir, with interesting topics ahead. And our platform is always available for this kind of academic initiatives. Thank you and take care, sir. Thank you, Dr. Rao. Thank you, Dr. Ranjan Shetty, for your time, sir. And all the participants who have taken their time out in their busy schedule. Take care, sir.